To introduce Dr. Ann Bailey. She's a fourth-year neurosurgical resident and a PhD candidate at the surgeon scientist training program at the University of Toronto, where she's pursuing a doctorate under the supervision of Dr. Ivan Rodanovich in the Department of the Laboratory Medicine and Pathology. Dr. Bailey's work is focused on understanding the biology of arteriovenous malformation to advance the field of targeted therapeutics and its clinical management. She has been awarded the prestigious Vanier Graduate Scholarship in recognition of her academic and leadership accolades. As an aspiring surgeon scientist, she aims to develop a robust endovascular practice for neurovascular conditions and hope to continue dissecting the basic biology driving angiogenesis to develop therapeutic strategies and target to modulate the vascular angiogenetic potential. We're excited for her talk today titled Defining the Role of MEK Inhibitors as Targeted Therapeutics for AVM Care. Dr. Bailey, thank you for talking to us today, and please go ahead.
Great, thank you so much for having me. I'm just going to share my slides now. Okay, excellent. Thank you everybody for having me here today. It's such a privilege to be able to share with you some exciting things that we're developing in the future of targeted therapeutics for neurovascular care. So my name is Dr. Bailey, and Mansur Bailey, and I'm, as mentioned, a PhD student, but I'm also a neurosurgical resident. So I've been trying to focus my graduate degree around more of a translational aim to both understand the biology of arteriovenous malformation, but also hopefully take that information and develop therapies for our patients in neurovascular care. My supervisor is Dr. Ivan Rodanovich, and he's a neurosurgeon at Toronto Western Hospital. And this is actually where we work. So a bit of a different landscape than Seattle, but I've done my undergraduate medical and a PhD degrees at University of Toronto, and it's a great city because we do also have a lot of opportunities for collaborations amongst the different hospitals and academic centers. There are 3 adult hospitals and 1 pediatric neurosurgical hospital in Toronto, and we also have the Mars building where we have a lot of scientists or pure scientists that help us with a lot of our genomic work. And I've really been fortunate to make use of a lot of these collaborations. So the work that I'm going to share with you today actually is definitely a collaborative effort, not only amongst the various different physicians, including endovascular surgeons and neurologists and pathologists, but also various scientists across the city that help to make this happen. So without further ado, so I'm sure a lot of you know that arteriovenous malformations are part of a larger spectrum of vascular malformations, but they consist of abnormal channels where arteries directly shunt into a low flow venous system without an intervening capillary network. So that high to low flow pressure obviously poses a risk for hemorrhage. And so depending on where the AVM is located, whether it's in the brain or in the body, bleeding is definitely one of the common manifestations. If it's located peripherally, we of course see patients presenting with pain, deformity, rapid overgrowth type syndromes, as well as functional deficits. And if they're located in the central nervous system, of course, patients also present with neurological deficits and significant morbidity and mortality in a relatively young population. So in terms of the more conventional management options for AVM, so microsurgical resection is certainly has always been a part of our conventional paradigm. There are also options for endovascular embolization, so minimally invasive techniques to reduce the flow or completely shut off the blood flow to the AVM. And if it's located in the brain, there's also stereotactic radiosurgery. So unfortunately, though, many of the complex AVMs and as well as many of the AVMs of the body remain untreatable and are either left to conservative management or palliative care, essentially. And the concept of medical therapies has not yet been defined as an adjunct to this treatment armamentarium. medications or the concept of targeted medical therapies for vascular malformations in general is not a novelty. It's actually been something that's been slowly developed over the last, I would say, 2 decades, with our increasing understanding of what are the what's the molecular biology and what are the mutations that are incurred in these malformations. And so our knowledge initially started with familial cases and slow flow malformations such as venous and lymphatic malformations, whereby we know that there are mutations that are part of the PIK3CA-AKT-mTOR pathway. And there is another parallel pathway, which is the RAS-MEK-ERK pathway. Both of these pathways are essentially involved in every one of our cells, and they're very important for proliferation, growth, and differentiation, as well as angiogenesis. But specifically, the PIK3-AKT-mTOR pathway has been implicated in slow flow malformations, for which there are various medications or targeted therapies that have been extensively studied, and we have a lot more knowledge and familiarity with these medications for these indications, such as sirolimus, which is an mTOR inhibitor, and alpelisib, which is Piqray, as well. So we've kind of gained the idea that we could repurpose some of these what we call cancer drugs for vascular malformations with some success. And of course, the success for slow flow venous malformations has not been super high, on the realm of 30 to 40%, but nevertheless, it's been adopted more and more in our clinical practice. And we do see a lot of our vascular surgeons in our city, as well as across the US, that offer these medications as part of a clinical practice. But how about AVMs? So high flow AVMs, the initial concept of utilizing medications was really to try to, what we say, stabilize the vessel wall. So the idea is that, we knew that AVMs are highly inflammatory lesions and obviously angiogenic. And so initially there was a concept of using tetracycline derivatives to deal with the inflammatory response in AVMs. And unfortunately, an early trial for that was not successful due to dose-limiting effects. Next, a group looked at the use of Avastin or bevacizumab, which is an anti-VEGF a molecule. So VEGF kind of works higher up in the cascade as a androgenic master molecule. And while it decreased the overall VEGF levels in the serum, clinically there wasn't any change in the AVM, and this is an AVM of the body, with no particular adverse events. So I think there was a lack of funding to make this kind of particular project continue. So we don't actually know further on whether Avastin can amount to further clinical benefit. The most recent and most robust study that is that of thalidomide. So this was given in Europe for patients with palliative vascular malformations of the body in adult pediatric patients, and they did see that there was improvement in symptomatology with adverse events being kind of more dose dependent, so lower in the lower dose administration. But all of this predated our knowledge of a specific pathway that underlines the pathogenesis of AVM. So specifically a finding that the KRAS pathway is both necessary and sufficient to drive AVM biology. So all of these molecules are a little bit more general, but do not necessarily target specifically the underlying pathway in sporadic AVMs. So as I mentioned, our lab in 2018 made the seminal discovery that the vast majority of endothelial cells in sporadic brain AVMs harbor this activating KRAS mutation, and that this KRAS mutation essentially results in abnormal phenotypes, so that it increases the activity of downstream. So ERK is downstream of the pathway, so ERK phosphorylation. It increases notch signaling in VEGF related angiogenesis genes, as well as the migratory and adhesive properties of the cells. And all of this was reverted with the in vitro application of a MEK inhibitor. So as I mentioned before, MEK is just downstream of the KRAS pathway. So targeting that essentially reverted these clinical molecular phenotypes. Next, there was our collaboration with Dr. Fish at the Mars building. We were able to show that the abnormal phenotype of shunts, sprouting, and hemorrhage was able to be induced in KRAS mutant animal models with zebrafish and mice. And equally importantly was that the use of a MEK inhibitor reverted these phenotypes again. So we had the idea, of course, so far in the community that MEK inhibition might play a seminal role then for AVMs, given its activation of the pathway. And so trametinib is actually a MEK1 and 2 allosteric inhibitor that's being used in and actually FDA and Health Canada approved for various KRAS mutant pathologies and oncology. So specifically things like metastatic melanoma, lung adenocarcinoma, et cetera. And so the couple of groups thought of repurposing this MEK inhibitor for palliative AVMs of the body. And so there are two isolated case reports of a pediatric patient, so 2 patients that had AVMs of the chest wall. And these patients essentially had very aggressive disease. They were started initially, one patient was started on sirolimus, so that's the mTOR pathway inhibitor, and not surprisingly progressed through despite that medication. However, within the first 6 months of receiving oral trametinib every single day, there was marked decrease in the size, the redness, the pain, and functional deficits associated with the AVM, as well as decreased flow to the AVM. And one of the patients also had an extension of this, thoracic wall AVM into their spinal cord. And we also observed that there was a decrease in the shunting, medullary shunting with administration of trametinib. So this was the very first, I would say, documentation of successful repurposing of trametinib, which is a MEK1 and 2 inhibitor, from robust oncology experience to extracranial AVMs. And again, extracranial AVMs and AVMs of the central nervous systems converge in terms of their molecular biology on the KRAS pathway. They have slightly different mutations, but ultimately the same pathway is activated. So here we have our first clue that maybe this is not only helpful in terms of the animal model and in vitro models, but also in the human experience. And in terms of adverse events, these patients had very mild adverse events, mostly cutaneous toxicities. So, next we wanted to understand then, trametinib is most likely the best drug for us to target because it targets the most relevant pathway downstream of these multiple angiogenic signaling cascades. And we also have the most robust clinical safety data in the oncology world. And so we decided to then try to use this MEK inhibitor and understand if it's safe and effective as an anti-angiogenic agent to improve upon AVM symptomatology, natural history, and angioarchitecture in adult patients with AVM. So we mostly serve the adult AVM population. So with that, we explored 3 aims, and these have been essentially a little overview of what my PhD has been about. The first aim has been to explore more of the clinical efficacy of trametinib in adult patients with AVM. So that includes patients with palliative AVMs of the body, as well as AVMs of the brain and central nervous system. Next, we wanted to understand more about the molecular and cellular effects. So how is this drug actually exerting its effect? Not so much in the cell lines that we've done before or in animal models, but specifically on human-derived AVM tissues. And really to try to dissociate and tease out the effects of the drug on specific cell types that contribute towards AVM pathology. And lastly, what we wanted to do is to optimize and validate more minimally invasive techniques in order to detect the somatic burden in various types of vascular malformations. So that way we can more reliably target in the future various medications. As I showed you before, there are a variety of different drugs that are currently being investigated. So while I'm focusing on trametinib, in the future, there might be options for various different types of targeted therapies, but we need to know exactly what we're targeting. So that has been my third aim. So towards our first aim, what we've done is we developed actually a compassionate use program whereby adult patients who have been deemed palliative as part of our multidisciplinary conference across various adult hospitals, are able to receive trametinib from Novartis directly, free of charge, essentially as part of a clinical care. So we follow the patients that are receiving the medications. And so here I present essentially 4 patients that had palliative AVMs of the body. And we actually have a robust and long-term follow-up data. So there's an average of 2.2 years follow-up, but some patients have up to 4 years follow-up. So that's been quite helpful for us to understand the trajectory of these patients on the medication. Ultimately, what we try to do is we try to stratify the treatment response to essentially go from no response to more subjective improvements in specific patient symptoms on a 10-point Likert scale, an objective response on physical examination, and an objective response of the AVM. So looking at the AVM natural history with bleeding. So these patients, because they're located extracranially, oftentimes the bleeding rates is pretty high. So we're able to quantify that. And lastly, we looked at the MRIs and quantified the overall volumetric response with 3D ROI segmentation. We looked at the safety, so quantification of adverse events with the classification. And whenever possible, we tried to get blood directly from the AVM at the time of an angiography, so embolization attempt, to then recapitulate the mutation with a liquid biopsy technique and cell-free DNA. So this is our first patient. She's a 56-year-old female that had a progressive AVM of her cheek. And she had multiple endovascular attempts. And at some point, they said essentially that there would be no more options, especially for her. She unfortunately had not only deformity and pain, but also infiltration of her ear, so reduced hearing on that side. She started daily oral trametinib, so it's a 2 milligram daily oral dose for adults. And within just 6 months, you can see a marked reduction in the size, redness, and deformity of her AVM. So looking at pictures A to C. And also there was reduced infiltration of her ear that resulted in an improvement in her hearing. And you can see in terms of her imaging as well that there was a reduction in the AVM nidus and as well as swelling of her cheek. She actually had a marked radiological response. So within 6 months to about a year, she had about almost 40% reduction in the total AVM volume. So we did see that there was a refraction of her vessels as well as reduction of the vascular caliber on angiography. All of this to say is she had these improvements both clinically as well as radiologically, and improvements as well as in her AVM natural history with reductions in bleeding. And her side effect profile was overall mild to moderate with mostly kind of cutaneous toxicities, but never any serious adverse events. She actually went from being palliative to being bridged to conventional therapy. So her first ever description of trametinib being able to ameliorate an AVM so much so that she is now offered surgery. So she had sustained clinical benefit from the drug for about 3 years, underwent surgery, and the plan essentially was to continue the medication for her after the surgery. Unfortunately, there was an issue with drug supply, so Novartis was unable to give us the drug for a period of time. And what we were able to observe during that off period was that she had marked rebound growth of the AVM, almost back to her pre-treatment size. And that is actually not uncommon when we have the experience of targeted therapeutics for vascular malformations, because we do see patients that receive sirolimus for low flow vascular malformations that when they stop, there is rebound growth. Nevertheless, when she reinstated the medication, she had yet again a similar robust reduction in the AVM size within the first couple of months of restarting the medication, indicating that in her case, there wasn't any resistance mechanisms to the drug, even after 4 years. So overall, now you can see that she's at almost about a 40% overall sustained reduction in her AVM and continued clinical benefit on the medication. She was a patient that we had a positive liquid biopsy. She was positive for a KRAS mutation. We externally validated that as well as confirmed that with the same variant found in her tissue upon surgery. In terms of some of the other patients, they had a maybe a less obvious or less robust, but still clinically relevant and meaningful change on the drug. So patient 2 and 3 and 4 all had improvements upon their symptomatology with reduction in the redness and sometimes even complete cessation of pain while on the medication. Patient 2 also had complete cessation of bleeding, and so did patient 4 had significant reduction in bleeding. So improvements upon the natural history that are afforded with the medication. Patient 4 also had a significant reduction in the size of her AVM, and so she's now also being potentially considered for bridging in the future. So here's a general summary. So again, this is the first ever description of the use of MEK inhibitors for adult patients with palliative AVMs of the body. And this is obviously not only the first, but also the largest description with long-term follow-up. So all of these patients had at least a year follow-up and some even up to 4 years. 3 of the patients we had blood available, and all of them were positive for KRAS pathway mutation. And all patients had at least a symptomatic improvement. Some patients had an improvement in the natural history with reduction in bleeding rate, and 2 patients had a reduction in AVM size, with 1 already bridged to surgery. In terms of drug-related adverse events, they were all pretty much consistent, but no patient had serious adverse event. So when we looked at essentially also at the tissue, we took patient 1, since she already underwent surgery, and compared it to a patient who had a similar AVM of the cheek, but did not receive trametinib prior to their surgery. And we see that the drug exerts its effect on the appropriate pathway with decreased of ERK phosphorylation. So remember, ERK is downstream, but we do not see a robust activation of the parallel pathway, the PI3K-AKT mTOR pathway, with long-term MEK inhibition. So in the case of oncology, oftentimes when patients are resistant to the medication, one of the resistance mechanisms is that the parallel pathway then gets activated. And we don't necessarily see that in patient 1's sample. And I think that kind of goes in hand with what her clinical experience was, is that she continues to have improved symptomatology and reductions in the size even 4 years later. And we also see with Ki-67 staining, so that's a staining for proliferation, that there's a reduction in proliferation with MEK inhibition. We submitted these samples for single nucleus RNA sequencing, and I have analyzed them the last couple of weeks just to say overall that we do see that the drug exerts an effect on remodeling the AVM cytoskeleton and an extracellular matrix to improve upon its shape and allow for those vessels to regress in some areas and then remodel with changes in blood flow in the healthy areas. So that's been very exciting to describe the various pathways and different genes that are involved in that process. So we've learned quite a few lessons in the last few years with regards to what the MEK inhibitor can be considered for in the adult populations with palliative AVMs of the body. I think most importantly and most ubiquitously is that it affords a symptomatic relief. And that's actually the primary aim when we work with patients that are of the palliative cohort. And so that's been quite exciting. Of course, the degree to which patients improve upon their symptoms is different and heterogeneous. So some will be more rapid responders, and others maybe have more of a mild effect. But nevertheless, it certainly should be the primary reason why we offer this type of medication to this patient population. For many of our patients, as I mentioned, it was also helpful to improve upon the natural history with reductions in bleeding rates. So a lot of these patients go to the emerge frequently with bleeding crises. And so we've seen that our patients really had a reduction in that facet. And only maybe a subset of patients who, for some reason, and again, we don't quite know yet because we don't have enough data to date, but for some reason, some patients have more of a aggressive response to the medication, whereby the vessels also then shrink, and the whole AVM tissue then responds and reduces in size. So in that case, then it could be considered not only as a long-term therapy, but also one that can be bridging patients who are palliative to more conventional therapies, either like surgery or embolization. One other lesson that we learned is that the concept of, rebound growth. So there really should be a plan if they're a physician who's using this medication of what is the end game, how long can we keep this patient on the drug for, whether we're bridging to a conventional therapy or not. And so trying to avoid situations where patients should be on the medication but are not receiving it, because certainly they will unfortunately experience a period of aggressive rebound growth that can be quite uncomfortable and painful, and obviously very stressful for the patient to undergo. And lastly is the toxicity management. So there's a really robust evidence of the types of adverse events that can happen on this medication from the oncology literature. And our experience to date with patients with AVMs kind of mimics that. So I think that really speaks to being more proactive as opposed to reactive in mitigating some of these toxicities, especially in patients with AVMs who might essentially be on the medication indefinitely. Okay. So our next aim is that we wanted to understand how the MEK inhibitor affords these clinical effects at the more molecular and cellular level. And, I showed in the first few slides about our lab's work in 2018, showing how the MEK inhibitor reverts some of these molecular effects, but those were in cell lines. And so now we wanted to validate that essentially from human-derived tissues, and not only looking at the endothelial cell, but also looking at the other cells, such as the supporting cells and the glial cells in the AVM tissue. So a bit of a busy slide, but I just wanted to show an overall workflow of what we've been doing. And this has been in collaboration. Some of this work has been in collaboration with Dr. Jason Fish, who's a basic scientist out of the Mars building, and his PhD student, Rulin Wu, who him and I have worked quite closely on some of these projects. So of course, myself coming from a little bit more clinical background and him having a pure science, basic science background has been quite helpful collaboration between the two. So essentially what we've done here is we've harvested, so we've taken AVM tissue from the OR. So Dr. Radovanovich or Dr. Andrade at our hospital operate on these. And I've essentially gently digested the cells, and we've labeled the cells with a CD31. So CD31 antibody essentially is an antibody for endothelial cells. And so we magnetically sort for endothelial fractions. So there'll be an endothelial cell enriched population, and then there's an endothelial cell depleted population that has all the other cells. After sorting, we then do ddPCR just to look for the presence of mutations. We then look at the protein expressions in the two cell types and how the drug versus DMSO, which is a control drug, affects various different types of protein expression. And then we looked at functions, so things like sprouting, proliferation, and cell death are readouts for angiogenesis. And we looked at how the effect of the drug on these readouts in each of the cell types alone in conjunction with one another. So this we've done for about 4 to 5 AVMs so far. And then parallel, we've done a harvest of AVMs in single cell isolation, whereby we treated half of these single cells with the drug and the other half with DMSO, which is the control. And then we submitted these for single cell RNA sequencing to look at the effect of trametinib on gene expression in AVM, human AVM cells. So today I really focus on the results of the more cell culture as we are still waiting on our sequencing results in the next few weeks. Okay. So what we found in our 5 AVM patients samples is that 2 patients had a positive KRAS mutation, and not surprisingly, this was positive only in the endothelial fraction. So to date, we have always described the mutation being on the endothelial side and not being present in the supporting cells. So we confirmed that, and we're able to validate that in this experiment. We also looked at other more novel mutations that work downstream of KRAS, and we did not find things like RIT1, and we did not find that in our patient population. So next, what we looked at is to say, the whole aim was to essentially isolate endothelial versus non-endothelial fractions. And so by looking at immunohistochemistry and immunofluorescence, we confirmed that the CD31, which is the endothelial marker, was only enriched in the endothelial-rich population. So that kind of worked. It's not uncommon, though, to have smooth muscle cell and pericyte contamination in the CD31 enriched population, just because we're not depleting for that, and that's totally fine. And we do see that with administration of the drug that there's maybe more expression of supporting cell types. That is just to say that they, generally speaking, have more of a proliferative advantage. So when you're slowing down the expression of endothelial cells, you're just going to see more of the supporting cells. Okay. So what happens in pathway signaling in response to the MEK inhibitor? So as I mentioned before, the general pathways, the main pathways that we look at are the KRAS MEK ERK pathway and the PI3K AKT mTOR pathway. And what we see here is that in both the endothelial cell as well as in their supporting cells, that the drug essentially decreases phospho-ERK, so it works on the KRAS pathway. And this is the first that we show that it also does that in the supporting cells, which I'm not surprised about, really. But what we also saw is that in doing so, within just 24 hours of administration, we do also see robust activation of phospho-AKT. So that's the parallel pathway that we typically see when there's a mechanism of resistance. So in these brain AVM cells, especially in the supporting cells, things like, pericytes and smooth muscle cells, they're really robustly expressing the parallel pathway with MEK inhibitor. So this is not something we saw in our extracranial AVM tissue, but it's really showing us that potentially the effect of the drug might be a bit limited or limited in comparison to the extracranial experience because it's really activating other parallel pathways that we were hoping it wouldn't. Nevertheless, we also saw an effect of the drug on other pathways that we don't show here, and it also reduced P65, which is essentially a marker of inflammation. That's actually quite important and relevant just because we know that brain AVMs can be very inflammatory. And one of the things that happens with inflammation is that it predisposes for rupture. And so, we were interested in the fact that there was a decrease in markers of inflammation on our protein expression experiments, because potentially that might mean that the drug might afford some sort of protective effect in the face of rupture. Of course, that needs to be validated, but nevertheless, that's an interesting off-target effect. How about the functional assays? So sprouting is essentially one of the main kind of phenotypes in AVMs, and it's how they grow or how they connect between endothelial as well as supporting cells. And so the spheroid formation assay is essentially a typical assay for sprouting, whereby normally it's just an endothelial cell that's put on a matrix, essentially. So the matrix is supposed to represent kind of like a basement membrane and extracellular matrix that happens in vivo. And essentially, this endothelial cell creates sprouts that are being fed by the media above, and then are fixed and stained after 24 hours. What we've decided to do is take it over to another level, whereby it's not just an endothelial cell that's in there, but essentially we compare the endothelial cell types and combine them with their supporting cell types, essentially to create some sort of organoid. So it's an AVM organoid whereby we control what are the different cells that are in this interaction in order to tease out the effect of the drug on different cell types and in different cell interactions. We're also able to store the media that's above, and we're able to analyze the media for different proteins that are in there. And that's a readout of what happens, the angiogenic readout of what happens in their interactions. So first we looked at is the endothelial cell. We compared the AVM endothelial cell alone to a primary brain microvascular endothelial cell. That's essentially just a normal endothelial cell that comes from a brain. And not surprisingly, we saw that the AVM endothelial cells are more angiogenic. They have increased.
Dr. Bailey,
Yes.
sorry to interrupt. Could I, just so we can see that right-hand graph, can I get
Oh, I
you to
apologize.
minimize your,
Oh, yeah. Sorry, I didn't realize that was there the whole time. Okay,
thanks so much.
no problem. Thank you so much for letting me know. So essentially what we've seen here is that the AVM endothelial cells are more androgenic with increased sprouting. That's not surprising compared to primary brain, like normal microvascular endothelial cells. and that the drug essentially decreases the sprouting potential. So sprouting potential is quantified by length and number of sprouts, specifically in AVM endothelial cells more than normal cells. What I thought was actually more interesting here is, people haven't really been looking at what happens in the supporting cell types. There's always been a focus around the AVM endothelial cells, but what happens when we look at the supporting cell types? So what we did is we took primary, like a normal endothelial cell line, so that's a HUVEC, and we compared it by combining it together with a temporal lobe smooth muscle cell. So these are supporting cell types that we got essentially from the same type of isolation I showed you before, but this time the originating tissue is a vessel that I got from a temporal lobectomy surgery. So it's a cortical vessel, so it's supposed to be a normal, healthy, quiescent vessel compared to an AVM vessel. And so when you add a temporal lobe supporting cell type to a endothelial cell line, it really doesn't do anything. It doesn't change the sprouting potential. Whereby if you add an AVM supporting cell type, it actually robustly increases and supports angiogenesis by increasing the sprout length and number. And once again, trametinib significantly reduces the angiogenesis whenever the AVM cells are around. So schematically, what we can understand from that is essentially, the temporal lobe endothelial cell primes its supporting cell to be quiet. That's why we have in a normal brain vasculature is that it's quite quiescent. And this quiescent supporting cell remains quiescent even in these assays when combining it with cell lines. Whereas the AVM endothelial cell tells its supporting cell, you need to robustly support and enhance our sprouting. And so when you add this supporting cell type that is primed to be highly angiogenic, it remains that way even in these cell lines. So in conjunction with HUVECs, it really supports their aberrant sprouting. When we look at the combination of human AVM endothelial cells with either quiescent smooth muscle cell or AVM smooth muscle cell, again, there's more sprouting whenever we combine it with a smooth muscle cell. So the doses between the two are synergistic, sorry. And once again, trametinib reduces more significantly the sprout length and number when you have the AVM smooth muscle cells present. Next, what we did is we looked at the secretome. So again, that is what is in the media between all of these interactions, and we saw that essentially there's a reduction in metabolic and inflammatory and angiogenic proteins in response to the drug. And then, specifically the inflammatory part again supports what we saw earlier with our protein expression, looking at the anti-inflammatory role of MEK inhibition. So far, I know this is maybe a bit busy with all of our experiments today, but we essentially showed that human AVM endothelial cells have more aberrant sprouting compared to normal brain microvascular endothelial cells, and they respond to trametinib therapy. More interestingly is that their supporting cells have a robust ability to promote their sprouting and are most sensitive actually to trametinib therapy more than even the endothelial cell alone. And adding these together significantly enhances their sprouting potential. So the idea is that the human endothelial cell prime their non-endothelial cells to facilitate this aberrant sprouting. And what I don't show here is that this is driven by the KRAS mutation. So we've done other experiments to prove that. And that trametinib, while it reduces sprouting across all cell types, it specifically does this in the presence of KRAS mutant cells. So the presence of the KRAS mutation is important in predicting the degree to which the cells respond. How about in addition to sprouting, what happens with proliferation and cell number and cell death? So again, we see that trametinib affects proliferation by reducing proliferation in both endothelial as well as the supporting cell types without inducing apoptosis. So that's important that we don't see necessarily cell death in these AVM cells. How about the patient experience? So what we decided to do is look at our palliative patient cohort. And we have several patients that have been on this medication, of which some of them unfortunately have not tolerated the medication well due to their toxicities, but others have been on the medication for more than a year. And we do see that there isn't as robust of a clinical response in the patients with AVMs of the central nervous system as there is for patients with AVMs of the body. And only one patient, we did see some slight reduction in the peripheral vessels, so decrease in the periadrogenic vessels in the lumbar region. But everybody else, essentially, their AVM angioarchitecture essentially remains generally stable. However, we don't see recurrent bleeding or progression on the medication. So summary of our results is, we started off having essentially no information about whether this drug would work and what kind of indication it would serve in a AVM adult population. And since then, we've really defined its role specifically in the extracranial AVM cohort in providing symptomatic burden relief and improving upon a patient's natural history. And in some cases, we do see quite a robust reduction in size and reversion of these vessels from a molecular standpoint that is actually driven by changes in how the cells interact with one another and how they change their extracellular matrix and remodel it to be conducive towards a stabilization. And we don't see necessarily, we only have tissue response for one patient, but we don't see necessarily a compensatory activation of other parallel pathways that would drive resistance in this cohort. In terms of trametinib for AVMs of the central nervous system, it still works, but we see on the molecular level that it's really providing an anti-angiogenic, an anti-metabolic, and anti-inflammatory effects on not only the endothelial cells, but all the supporting cell types that are around them. However, we don't see any cell death or necessarily regression of these existing vessels on our clinical imaging. And so perhaps we can consider the use of trametinib for AVMs that are more rapidly progressive or aggressive with their bleeding rate. The idea more so to halt progression as opposed to reverting it or reducing it in size. We are at this point waiting for our sequencing data, so hopefully understand a little bit more information about how it's exerting its effect on transcription. And I think that'll be interesting to compare the transcriptional readout for our brain versus extracranial human patient tissue to get a sense of how it works differently. Just because we know that the pathway is the same, but certainly the biology is not exactly the same between the two. And lastly, we have this idea from this is that, perhaps we can consider in the future combinatorial therapies. So things like, for example, combining the MEK inhibitor with something like, radiosurgery or gamma knife, where that exerts more of a scarring and fibrotic effect to really help with reduction of those vessels. So understanding at a preclinical level whether combining a medication with a gamma knife might be synergistic, because we know that it has an anti-angiogenic effect, but maybe not so robust that it would actually reduce the size of those vessels that maybe gamma knife could help with. Lastly, our last aim is we wanted to optimize and validate minimally invasive approaches in order to understand a patient's mutational burden and vascular malformation. So I slightly touched upon this in our first aim when I showed you about a liquid biopsy that we got from some of our patients. But we really kind of grew this idea across a variety of vascular malformations, not just AVMs. And so essentially what a liquid biopsy is we're able to detect mutations from cell-free DNA that is shed in bioavailable fluids. And so the first step is essentially obtaining a bioavailable fluid. And in this case, for AVMs and vascular malformations, the most logical one would be blood. However, detection of mutations in oncology has been quite long-standing and is used actually in clinical practice. The reason why is that circulating tumor DNA is quite abundant in oncology. However, the presence and the degree to which cell-free DNA is present is much lower in AVMs than it is oncology. So it's a bit more challenging to detect, which is why when you do a peripheral blood draw, it's always negative, whereby you need to actually obtain a blood that is intimate with the AVM. So in order to do that, you essentially have to take it at the time of a endovascular procedure. For the cases of AVMs, the mutation lies on the venous side. So that means that you have to take blood at the time of an endovascular approach where it's transvenous approach, because it will not necessarily be positive on the arterial side. So once you've obtained your biofluid, then next you have to extract the DNA. So we essentially spin, and there are multiple types of kits and technologies that can help to extract your DNA. One is a silica membrane approach, whereby the DNA can essentially bind to a membrane, and you kind of get rid of all impurities that you don't want to have, and then you then look at the DNA that way. Or you can isolate the cell-free DNA using magnetic beads approaches that, technically speaking, have been described to be a little bit better in the sense of not having things like pores being clogged and whatnot. But of course, you need to have the right equipment to do so. And next, we looked at mutation detection. If you don't know what you're detecting, you can do more next generation sequencing, like whole genome or exome approaches. But of course, that is limited by its level or degree that it can detect. Whereas ddPCR is the most sensitive approach. And in the case of the vascular malformations we looked at, such as AVMs, venous malformations, and lymphatic malformations, we actually know the mutations that we're looking for. So we decided to proceed with ddPCR. This paradigm has been done before. It has been actually published for slow flow malformations in AVMs of the body in about, I'd say, 4 to 5 or 4 to 10 patients. And so really what we've been trying to do is actually to optimize the workflow to better detect the mutations and also to understand whether that can be further applied to AVMs of the central nervous system. So in this process, we essentially have about 25 patients that proceeded with the study. For 10 patients, we actually had insufficient blood to run the analysis. And so for these patients, most of them were just a reflection actually of the patient population we serve. So at Toronto Western Hospitals, we have a high volume of sclerotherapy and bleomycin therapies for patients. And so a lot of these patients are actually redo, or they've had therapies before, they've improved, and so they come back. And so with each time they come back, there's more and more scarring and less blood that we're able to extract. So most of the patients were prior bleo cases that we just didn't have sufficient blood because it's shutting down. And for one or a couple of patients, we did have very distal brain AVMs that had prior embolization therapy. So of course, access and to get the blood is more diminished. We have quite a few patients that had slow flow and extracranial AVMs, but this is the first ever report of this being done for AVMs of the central nervous system, so brain and spinal cord, and we have quite a few numbers from that. So protocol optimization. The first question we had is to understand what is the minimum input of whole blood volumes in order to render the plasma that we need to actually do the liquid biopsies. So they all talk about what the commercial kits requiring a ml of plasma. While they always describe in their protocol 4 mils, this is usually of whole blood needed. This is usually not always possible for AVMs, especially, or for redo bleo cases. So we found that the cutoff for us was 3 milliliters rather. So anything lower than that, we generally are unable to render sufficient plasma for further assessment. So 3 mils is our cutoff. What about time to spin? So what we did is we used something called a Streck tube, which the Streck tube essentially has things in it to stabilize the blood. The companies that make them essentially says that you're able to have the blood there, quote unquote, stabilized for up to 2 weeks. So it allows you to spin them later and batch them, if you will. However, we actually found that the blood would degrade over time. And so especially where you have such low cell-free DNA present in AVMs, that the cutoff for us was to spin the blood within 24 hours. I think that's still pretty reasonable. Some labs do it within the first hour or two, which is clinically not so feasible, but I think 24 hours is still fine. Next, what we did is we compared the two isolation kits. So the silica membrane Chi-amp kit that's every lab has that, or the more Mag-Max, which is the negative bead kit. And essentially what we did is we saw that the positivity rate was almost significant. Ultimately, the yield of cell-free DNA was much higher with the Mag-Max. And I think that it can be explained by just the fact that it's isolated with a bead as opposed to being filtered out, which obviously has inherent issues. In terms of variant allele detection, so we had about 56% positive patients that are positive with some sort of KRAS pathway mutation or PIK3CA mutation. And importantly, the mutation matched the vascular malformation. So, we didn't see PIK3CA mutations in AVMs, for example, and vice versa. So this kind of mutational rate was makes sense compared to what we saw in tissue from our 2018 New England Journal paper. So we're not seeing more positive, higher positivity rate than tissue. Tissue will always be the gold standard, but certainly we've been able to validate some of these positive ones. So I've already shown you a couple of validations with our patients that had the extracranial AVMs, where we were able to get external validation at other centers. So we split the blood up amongst two groups, and we did the exact same experiment and got to the exact same result. But we also validated with tissue whenever possible. So our first patient with the extracranial AVM, for example, had the exact same variant with similar, the exact same variant, for example, in their tissue that they found in their blood. So all in all, the conclusion so far from this aim is that liquid biopsies using cell-free DNA from plasma can be safely done for patients with vascular malformations at the time of endovascular therapy. And this can include not only extracranial AVMs, but certainly also AVMs of the central nervous system. When doing this, you'd want to have a minimum of 3 milliliters of whole blood, and you'd want to spin the tube within 24 hours. If you have access to the Mag-Max bead kit, it certainly will yield a higher cell-free DNA for downstream assessments. And if you know the mutation you're looking for, ddPCR has the optimal sensitivity. Of course, we like to further validate the Mag-Max kits, and we want to understand also how far along the beam system can you still recapitulate the mutation. So we know at a peripheral draw that it would be negative. And we know that if you are very, very intimate, so really high up there on the efferent side of the AVM, for example, that you have the highest chance of getting a positive rate. But of course, that's very limited then to patients that are only going for an endovascular approach with transvenous access. So I think an intermediate question for us down the road would be to see whether we can recapitulate that at the level of the jugular, which many patients in ICU would have that kind of access. So all in all, from the work that I've shown you today, we can start understanding, our therapeutic approaches for neurovascular conditions in light of perhaps defining and designing a precision medicine approach. And this is not something that's, novel necessarily in medicine. Oncologists have been, working towards this for decades, whereby things like surgery and chemo, et cetera, are all still a mainstay, but their understanding of the biology of their diseases using, genetic material, whether that be tissue or blood or CSF, understanding the patient's mutations and, populations and biology of each various cell types, and then kind of designing appropriate targeted therapeutics to that. That's already been in play in oncology. And we now understand vascular malformations as kind of being quite similar, harboring similar types of mutations, having similar types of biology. So as we develop our understanding a bit more, we can then consider these targeted therapeutics as adjuncts to conventional therapies, whereby, as I mentioned, depending on your patient, you might want to use it for symptom control. You might want to use it to downgrade to afford more patients opportunities to undergo conventional therapies. it might be considered then as an adjuvant therapy or neoadjuvant therapy, just as we do targeted preoperative embo for vascular malformations before surgery. Maybe the drug can be used that way for vascular malformations before surgery. And we do have actually a clinical trial that I've opened up with Dr. Radovanovic in the last year, whereby we are looking at patients and the role of a MEK inhibitor and improving upon angioarchitecture neoadjuvantly before surgery, or it can be adjuvant, for example, with Gamma Knife. And lastly is the concept of drug synergy. So drug synergy, again, in oncology, most of the medications are not given alone, just because we know that there is a limitation in terms of how it exerts its molecular effect. And I've shown that as well in our data for both brain AVMs and extracranial, that it exerts a positive and antiagenic effect, but there's only so much that it can do. And so it's not a miracle drug, but knowing what its limitations might be, then kind of understanding where other drugs can then come in play to take on that role. And so I think this is a very exciting time because we are really developing more and more of an understanding of neurovascular diseases and their biology. And we have quite a rich armamentarium of therapeutics that can be repurposed or developed essentially that we can bring into our clinics in the next 10 years. So with that, I wanted to really thank, all of my collaborators and Dr. Radovanovic, who's been my supervisor, PhD supervisor and mentor, and Sandra, who's in our lab, Dr. Hugo Andrade, who's another neurovascular surgeon. The entire interventional team, as you can see, has been very important across a variety of our projects, especially our liquid biopsy projects. And the Jason Fish's lab, who's a pure basic scientists group, but have had a very big and important role in defining the molecular biology, and has been very helpful with us to design of our experiments, and of course all of our granting agencies that you see below. So with that, I wanted to thank you for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Bailey, for this very insightful talk. And the floor is open now to questions.
So the main thing I got out of this is just how little I understand the basic biology of AVMs, and it's amazing work. I'd love to understand more. I need to go back to very basic things about even about the inflammation. And when I think about patients and how stable they are for many of them, I mean, you run across the incidental AVM in a 70-year-old woman, and how do you get a sense of where is inflammation playing that role? How does it vary over time, and how does that impact what you're doing?
Yeah, so thank you so much. I think that's inflammation plays a seminal role, and I do agree that it's hard to predict when an AVM would be inflammatory, when it kind of has more of that quiescent phenotype. You, as you mentioned, rupture, you can never predict when it happens, and sometimes an AVM can be quiet for many, many years, and suddenly it ruptures. When we look at susceptibility studies, there's always been a link between inflammation, not only in terms of inflammation and AVM biology, but inflammation and rupture risk. So that's been established in terms of a correlation. In terms of causation, when we look at the AVMs that are ruptured, we can certainly see that there are a lot more inflammatory cells, like macrophages, that are infiltrating and are present in the AVM endothelial wall compared to unruptured AVM. So we know that they're around. What's interesting is that in addition to their presence is also the signaling. So there's a high signaling of interleukins. So a lot of different kind of inflammatory markers that are present and are actually signaling in not only the endothelial, but also the supporting cell types to exert this kind of inflammatory effect. And one of the things our lab, as well as other labs, have looked at, and we've developed this single cell atlas whereby we looked at cells across fetal, across normal, and then across other types of diseases, including malformations and brain tumors. And there was this idea that inflammatory markers were present not only in terms of AVMs, but across a variety of pathologies. And the endothelial cell was actually a very big, an important contributor to that in its interactions with inflammatory cells. There's actually a cluster of endothelial cells that actually have inflammatory markers themselves. So like they in themselves play a bit of an inflammatory role, which is very unique. Nobody ever thought of endothelial cells as being potentially inflammatory in themselves, but we saw that in AVMs. I don't know how to understand how to predict when an AVM would be more inflammatory or not. Certainly, I imagine, when you scan patients, you follow them in clinic and whatnot, that you can see that there's maybe a slight growth or, on angiography, perhaps you see a slight change in the vessel wall or maybe a little bit more, neoangiogenesis. There are times when we get a sense that the AVM is a bit more biologically active from imaging versus when it's a bit more quiescent. We do have a clue that might be driven to some extent by inflammation. Whether inflammation is a chick or egg, like whether it's responding to something or driving it is hard to know. In aneurysms, we do things like vessel wall imaging to look at inflammation, but in AVMs, it's hard to tell so far when it's happening and whether or not drugs that target inflammation will be more important than those that just target angiogenesis. It's important to know that the MEK inhibitor, I guess, does both.
So how important is it that you account for that when you're looking at the AVMs, when you're looking even at your liquid biopsies and an AVM might be a 6 centimeter AVM? How regional do you think the inflammation is within that AVM? It bleeds at a one point on one edge of the AVM. Is the inflammation generalized? How does that impact what you're thinking about the results you're looking at?
Mm-hmm. Yeah, it's really hard to tell. I mean, looking at because when we dissociate cells, we get them from all over the AVM, so it's hard to localize exactly where that is. We do know that certain parts of the AVM might recruit more inflammatory cells, and whether that's in areas that, for example, have had maybe prior microbleeds, so certain areas that are weakened. So one of the things we talk about stabilization of the vessel wall is just that, and other studies have shown is that the unlike normal vessels that are surrounded by smooth muscle cells and have all these tight junctions that kind of keep everything in place, that AVM cells, endothelial cells, are leaky. And part of the leakiness towards them is because they're not covered completely by these supporting cells. So there's actually a diminished a recruitment of parasites and supporting cells in AVMs. And there's also diminished tight junctions across them. And so these things together allow for inflammatory markers and cells to kind of come and interact with endothelial cells a bit more abnormally, I guess, and allow for both the hemorrhage and as well as the consequent inflammation that comes from that. So I think there are times maybe when we look at imaging, you can see there's some weakening or weak points that we can predict that's an area that it might bleed. I don't know yet if we can find ways that are areas that are weak in terms of the vessel wall and predict that that's where the inflammation is going to happen. I imagine there's a correlation, of course, weak points with inflammatory markers, but again, I can't really say for sure.
And then similar questions about the proliferation. I mean, my very crude experience with AVMs is I don't see them enlarging. The vast majority of them, you see occasionally a young person who, the rare case where you've actually removed an AVM and followed up on them 5 years later, and there's a new AVM maybe adjacent or sometimes even more distantly located. So, I think there is that phase of real proliferation in the younger patients that probably by adulthood is pretty stable for most cerebral AVMs. And which I wonder is that not quite different from some of these peripheral, these really horrible AVMs that you're seeing, that you showed us at the beginning of your talk, and in the cutaneous ones that really seem to be growing, proliferating. If you touch them, they explode, and they're just. Is that not a very different sort of spectrum, place in the spectrum in terms of proliferation.
100%. And I think that's one of the things that distinguishes peripheral AVMs from AVMs of the central nervous system. So, I mean, I didn't think that the anti-proliferative effect of trametinib that we saw on the extracranial AVMs was surprising. That's exactly what trametinib is intended to do, especially in oncology as well, is it's exerting this anti-proliferative effect. And so, you take an AVM that is highly proliferative and you kind of reduce that, then that together with this anti-angiogenic effect is also helping to shrink the AVM. We know that proliferation is not as an important readout and marker for AVMs of the central nervous system. There are some cases, of course, that can proliferate a little bit. We do see sometimes, especially what we call more biologically active AVMs of the brain, where we see a little bit more of a periangiogenic zone kind of developing, or you've resected and you do see a little bit of regrowth on the venous side if you haven't completely taken off the entirety of the venous outflow of it. Again, very not as robust as you see in pediatric, that's for sure. But at the molecular level, all cells proliferate, whether we see that clinically or not. The anti-proliferative effect of trametinib in CNS AVMs is less important. I think the more important thing for CNS AVMs would be angiogenesis, sprouting, and metabolism, which my colleague at Jason Fisher's lab really worked on metabolism and glycolysis of AVM endothelial cells and inflammation. Those are kind of the more important things in CNS AVMs, whereas things like proliferation are highly important and would be a major target for MEK inhibitor for peripheral AVMs.
Okay. Thank you so much.
Yeah, Dr. Monti, you have
Thanks, Dr. Bailey. That was really interesting and very well put together talk. I had a question about the role of Avastin post-radiosurgery. So, often we have radiation-induced imaging changes / swelling after a gamma knife for AVMs, and occasionally those patients are symptomatic and their condition is resistant to steroids, and we've used Avastin on rare occasions, and it's gone away or it's improved. So there appears to be some effect that's not just inflammatory, because the steroid should take care of that. So I was curious to see what you thought was going on and why Avastin works in that setting, given your experience.
Thank you so much. So tough question. I think long and short of it is I don't know. It's hard because, when you look at VEGF, it's just a master regulator, and I'm still grappling with so many different, complex interactions that happen in just normal angiogenesis, let alone what happens in abnormal angiogenesis. And it's unclear what happens when you only target one thing, if you're only targeting one pathway, what it's doing to the rest of the other pathways. And that changes in every patient. So it's not surprising that none of these drugs are kind of miracle medications. Otherwise, we would have a better understanding of it. Certainly, what happens in you do see some fibrotic changes after gamma. And actually, that's one of the way it works, is kind of having these proliferation of smooth muscle cells to kind of help shut the vessels down. How VEGF plays into that, I know there's signaling amongst all cells, and VEGF is there. Whether reductions in that help to help the smooth muscle cells kind of exert other kind of effects on the endothelial cell, I don't really know, but I think it's worthwhile exploring, just because from the literature we haven't seen that Avastin works on AVMs in and in itself. So how it plays in the synergy just shows that the interactions are quite complex, and if we understand those interactions better, then we would be able to design these kind of combinatorial therapies, just as we were thinking of designing, MEK inhibitor with, for example, gamma knife. But until those are done, it's everything's pretty much up in the air.
Thanks.
Or I couldn't give you more of an answer.
No, that's okay. I had one other question about with the liquid biopsy, you were talking about getting onto the venous side. A lot of the time, ruptured AVMs bleed from a perinatal aneurysm.
Mhm.
Do you think so? There's something abnormal, right, on that vessel because it's exploded. Can you get a liquid biopsy from there, or does it have to be on the other side of in the venous side? So, you've got this abnormality. A lot of the time we can't go past those feeding aneurysms. We have to embolize proximally, but sometimes you can get distally pretty safely, or there's multiple aneurysms and one of them, the third one or something, has ruptured.
Mhm.
Could you get a liquid biopsy from there, or does it have to be from the venous side?
It has to be from the venous side. We've actually done that. I didn't show the data on that, but a subset of AVMs we tried on both sides because we just had access. So we tried a very distal with microcatheter on the arterial side, basically almost in the nidus, like right up there, and then we also tried on the venous side, and I was not able to find the mutation on the feeding side, but I was able to find it always on the outflow of it all. So of course that it is challenging because you're not going to always have transvenous access for all patients. So I guess number one is if we can validate it at the jug, it makes it a little bit more, I guess easier to use in the clinical setting. But I think, oftentimes when you're trying to identify a patient's mutation, it means that you really need to know that information to drive a clinical question. So maybe you can then kind of justify the risk to go on the transvenous side if that actually is going to change your management. So that's kind of how we've conceptualized this idea. I don't think all patients require a liquid biopsy, but certainly down in the future when we start kind of teasing out different drugs and different combinations, it then knowing, what that patient might benefit from is going to be key.
Good, thank you.
Thank you.
All right. That was a wonderful presentation. Really appreciate it. We've kept you past the time we asked of you. So again, appreciate you being here. Appreciate you sharing that with us. And it's terrific work.